Hi, I'm Dr. Matthews. I'm here today to talk to you about some special populations that require exercise prescriptions that are modified from what the general public would get. I want to highlight a couple textbooks that I'm going to pull a lot of this information from. So both of these come from the American College of Sports Medicine, or the ACSM, and one of those is the Resources for the Exercise Physiologist, the second edition, and you can see the various chapters that I pulled some information from that textbook, and you can also scan this QR code here to see exactly which textbook I'm talking about and see where you can purchase it. And the other one is the ACSM's Guidelines for Exercise Testing and Prescriptions, the 10th edition, and you can see the various chapters that I'm pulling information from that as well. And again, here's the QR code that you can scan to see that textbook. Now, in this lecture, we are not going to be covering these different populations in a great amount of detail. We're just going to kind of give an overview of some special populations that you should be looking out for. And I'll show you in the textbooks where you can find information on the exact exercise prescriptions for those populations and the things that need to be modified. But we'll just kind of touch on that stuff. All right, so a lot of times this will be taught in a class all by itself. So it'll be a full semester-long course just on special populations and exercise prescription for them. But again, this is just a single lecture overview of those topics. So the things that we're going to be covering here are a little bit on the risk assessment piece for some of these populations, a little bit on exercise prescription. Let's start off by talking about atherosclerosis, because a lot of the conditions we're going to be talking about are conditions where atherosclerosis is present, or conditions that resulted because of atherosclerosis, things like people with strokes and things like that. Atherosclerosis is the buildup of fat as well as connective tissue and immune response cells that cause the narrowing of a blood vessel and potentially cause it to eventually rupture. Looking at this first artery here, this is a healthy artery, so you can see that the blood flow is able to go through nice and easily. If we go over to the next one here, this is an example of what's called a fatty streak. So basically you just have a little bit of cholesterol that builds up along the side of the cholesterol, or triglycerides that build up along the side wall of the inside of the artery, and this eventually is going to cause an issue. When it's just a fatty streak, it doesn't really cause any major health issues. In fact, most adults, even very young adults, 18, 19-year-olds, probably have fatty streaks in their arteries, especially in the industrialized societies around the world. So it's just mainly a product of our lifestyles. All right, so if the fatty streaks continue and the fat starts to sort of infiltrate into the wall, so getting under the endothelium, which is that inner wall of the artery, and it can cause these fibrous plaques. And this is basically when the collagen fibers start to overlap the fat that's infiltrated, and it causes this buildup. And this buildup is what causes the vessel to narrow over time. So when somebody says that so-and-so had a 50% blockage in an artery, that means they have this fibrous plaque that's built up enough that it blocked half of the artery's lumen here, so that blood flow couldn't get through that half. All right, so this is starting to get to the point where it's going to be concerning, and depending on how severe it is, it can be a life-threatening condition. All right, but what most people who have atherosclerosis eventually have happen to them, which is going to actually cause a life-threatening condition, is when they get complicated plaque. And typically a complicated plaque is a ruptured plaque. So you can see here that there's some sort of damage that happened. Blood cells push through forcefully, cause the endothelium to rupture, so burst open, and it exposes this inner tissue to the blood. And when that happens, the platelets here start to coagulate on top of the rupture, and it causes a blood clot essentially. And when that blood clots, you already have this narrowed artery, now you have a blood clot on top of that can cause a heart attack, a stroke, and other serious conditions that can lead to disability or even death. The most common form of atherosclerosis that you're going to see in clinical environments is going to be coronary artery disease. So coronary arteries are the arteries that feed the heart. So it's just this atherosclerotic process that I was just describing here happening in the arteries that feed the heart. So when you have a heart attack, that is atherosclerosis inside the coronary arteries. So that's coronary artery disease that's causing that. When somebody has atherosclerosis to the point where the vessel has narrowed and it starts to limit how much blood flow can get through the vessel, they can start to develop what's called ischemia. So ischemia is just an imbalance between the oxygen demand and the oxygen supply of a tissue. So any tissue of the body can become ischemic whenever the blood flow to it is not great enough to sustain the metabolism of that tissue. So it can happen in the heart, it can happen in the legs and the calf muscles, it can happen in the brain, it can happen in lots of tissues. So again, ischemia just means that there's a mismatch between how much oxygen is needed and how much oxygen is getting to the tissue where there's not enough oxygen getting to that tissue. The myocardium is the muscle of the heart. So myocardial ischemia means that the muscle of the heart is not getting enough oxygen. So in other words, that atherosclerotic process is happening to the point where the coronary arteries are not getting enough blood flow through them, and you're going to have a lack of oxygen supplying the muscle of the heart. All right, and so if this happens, it can oftentimes cause angina, which is just a fancy word for chest pain. And we have two different types of angina that we need to discuss here. We have stable angina and we have unstable angina. Stable angina results from when you have an increased myocardial oxygen demand. So in other words, if I were to get up right now and walk on a treadmill, my heart would work harder, and if my heart's working harder, that means it needs more oxygen, and that's what I mean by an increased myocardial oxygen demand. So if the oxygen demand goes up and you get angina, so you get chest pain, and then you maybe stop exercise and you sit down or whatever, or you just lower the intensity of exercise and that chest pain starts going away, that's typically stable angina. So it's a predictable chest pain. All right, so every time you get to a certain exercise intensity, chest pain starts, and if you lower your intensity and give it a couple minutes, the chest pain typically goes away. All right, again, that is stable angina. By definition, it is predictable. All right, so unstable angina, on the other hand, is not predictable. Unstable angina can happen at rest. It can happen when you just get excited. It can happen any random time, whether you can link it to some sort of increase in oxygen demand of the heart or not. And so unstable angina is much worse than stable angina because, again, stable angina is predictable. We expect it to happen at a certain intensity in somebody who's already been diagnosed with this condition. Where unstable angina, it's kind of hard to prevent it from happening because we don't know exactly when it's going to occur. And it's also a sign that there might be some issues where the plaques inside the arteries might not be stable themselves and might be causing blood clots or other issues where you're getting angina sometimes and not other times. If somebody is experiencing unstable angina, that is a sign that they need to seek a medical treatment immediately. So if somebody's getting chest pain when they're sitting down, when they're resting, when they're not doing a whole lot, or if they get a little nervous and they get chest pain, those are signs that they need to go seek medical attention right away. Now, there are other conditions, think of it like anxiety disorders, where chest pain can be a symptom, and that is caused by a very different process than atherosclerosis. And so don't think that just because somebody gets chest pain, it has to be myocardial ischemia and atherosclerosis. There are other causes, but a medical professional needs to be sought after to identify what's going on and diagnose the condition. When atherosclerosis happened in the coronary arteries of the heart, we had coronary artery disease. When atherosclerosis happens in the arteries that go out to the limbs of the body, so the periphery, so whether it's the arms or the legs or both, that is peripheral arterial disease. So it's the same exact process. It's still just atherosclerosis. It just, the name of the disease and some of the symptoms are going to change because of what parts of the body are being most affected. All right, so peripheral arterial disease, again, is a narrowing of the vessels. Typically, you're going to notice it mostly in the lower limbs, and it's going to be a result of atherosclerosis. So again, that narrowing the blood vessel from fat accumulation and other things that accumulate around the fats that eventually cause some issues. And one of the most common symptoms of peripheral arterial disease is something called intermittent claudication. Intermittent claudication essentially means that you get a predictable cramping sensation. So this cramping sensation is the same thing as what we were just talking about. It's a form of ischemia, right? So again, when you got ischemia of the heart, you get angina. When you get ischemia of, say, the calf muscle, that's called intermittent claudication. All right, they both cause a pain in that muscle. All right, so again, in the heart, the pain was called angina, so it's chest pain. In the calf or whatever muscle is being affected by the peripheral arterial disease or the PAD, that is going to cause pain in that muscle. All right, and typically it's going to be a predictable pain. So again, I feel nothing when I'm resting. If I start to exercise a little bit, maybe I'll feel something, maybe I won't. And then every time I get up to, say, 3 miles per hour on the treadmill, I get this pain in my calf. When I lower the intensity after a few minutes, where the oxygen demand has become balanced again, the pain goes away. If I go back up to 3 miles an hour, pain comes back. That's intermittent claudication. Again, it's usually a very predictable pain brought on by some sort of weight-bearing type exercise like walking. Because most PAD is going to occur in the legs, one of the most common tests for PAD is what's called the ankle brachial index. So basically what you're going to do is you're going to assess the systolic blood pressure in the ankle, and you're going to assess the systolic blood pressure on the brachial artery, so in other words in the arm, and you're going to look at the ratio difference between them. All right, so if you were to, again, divide the ankle systolic blood pressure by the brachial systolic blood pressure, and you get a value that is greater than 0.90, that is considered normal. All right, so most people are in this range. All right, if you get a value that is equal to or less than 0.90, that is suggestive of peripheral arterial disease or PAD. It's important, if we're going to talk about all these forms of atherosclerosis, that we should talk about blood pressure control. Just for a moment here. Blood pressure, so specifically hypertension, so high blood pressure, is one of the most common risk factors that lead to atherosclerosis. So if you were to scan this QR code here, you're going to see a website by the American Heart Association, or in conjunction with the American Heart Association, where you're going to see the current guidelines that were just released in November 2017 for hypertension. So they did recently change, just to give you the thresholds for hypertension, they dropped so that it's a little easier to be diagnosed as hypertensive now. Now if you have a systolic blood pressure of above 130 millimeters of mercury, well, equal to or above 130 millimeters of mercury, or a diastolic blood pressure equal to or greater than 80 millimeters of mercury, you now can be diagnosed as being hypertensive. In the past, it used to be 140 over 90. Again, now it's 130 over 80. So the threshold has dropped significantly. With this drop in the hypertension threshold, this is going to mean a lot more people are going to be diagnosed with hypertension. They're estimating that approximately 46% of the American adult population is now going to be hypertensive by this new threshold. All right, so it's unclear right now what the ACSM is going to do as far as whether they're going to adopt these new thresholds or not adopt the new threshold. When I reached out to them, they did not get back to me, so I'm not sure exactly if it's going to go with the AHA, so American Heart Association, and adopt this. I suspect that they will, because most people are going to be adopting this. Most organizations already have adopted this. I just am not clear on the ACSM yet. Something I want to keep in mind, you as an exercise scientist are not qualified to diagnose. You are only there to suspect that there may be a condition. So you are called a suspectician, not a diagnostician. So you should be measuring people's blood pressure, and if you suspect they might have hypertension, you should be referring them to their medical professional. And also keep in mind that just because somebody has a high reading once doesn't necessarily mean they have hypertension. You need to have high blood pressure readings on at least 2 separate visits to be considered hypertensive. Another thing I want to point out here, even though they lowered the thresholds for being considered hypertensive, they did not lower the thresholds for when they start to give antihypertensive drugs. So don't be alarmed if you're suddenly above the hypertensive threshold. That doesn't necessarily mean you have to go on medications right away, but you should talk to your healthcare provider or refer your clients to their healthcare provider in order to figure that out. Another thing I want to point out here that is if you are working with a client and they are on some form of hypertensive medication, regardless if their blood pressure comes up in a normal range or not, you should treat them as a hypertensive client, because by definition, if you are on hypertensive medication, you are hypertensive. Again, regardless of what their blood pressure actually is, it's probably going to be medicated within the normal range or pretty close. They are still hypertensive even if they are in the normal range if they are on hypertensive medications. Let's talk about diabetes now. So diabetes mellitus, there are two types. There's type 1 and there are type 2 diabetics, and they are caused by very different things. Both of these, though, is going to be a decrease in the production, the release, or the effectiveness of insulin. All right, insulin is the hormone in the body that's going to take the glucose, which is sugar in the blood, and it's going to bring that sugar into the cells of the body. All right, so if you have an issue with how much insulin you're producing, how much insulin you're releasing, or how effective, how sensitive your body is to that insulin, that's going to mean that you're going to have a higher amount of glucose in your blood, just walking around randomly, sort of at rest, and that can over time cause a lot of issues, cardiovascular disease, and lots of other problems. All right, so let's talk about the different types of diabetes now. So type 1 diabetics typically are diabetic because they don't have enough insulin being released into the blood. All right, so these are diabetics caused by a destruction of the pancreatic insulin secreting beta cells. So the beta cells of the pancreas is where insulin is made, and it's released into the bloodstream, again allowing the blood glucose to enter the cells of the body. So type 1 diabetics typically have some sort of autoimmune disorder or some sort of injury that happened to their pancreas that killed off enough of the beta cells where they are no longer capable of producing enough insulin to regulate the blood glucose levels. All right, so type 1 diabetics, usually some sort of injury or autoimmune disorder. Type 2 diabetics is usually caused by insulin resistance. Insulin resistance means that your body is less sensitive to insulin than it should be. In other words, if this person has this amount of insulin and this person has this amount of insulin in their body, maybe this person over here is a typical individual that's not a diabetic, or this person has diabetes. This person over here with the diabetes is going to have high blood glucose, where this person that doesn't have diabetes, their blood glucose is going to be in normal range. Even though they have the same amount of insulin in the body, the person who is diabetic is going to have insulin resistance. Type 2 diabetic is going to have insulin resistance, and that's going to decrease how much of the glucose gets pulled out of the blood and into the cells with a given amount of insulin. All right, so again, type 1 diabetics, some sort of autoimmune disorder or injury, meaning causing not enough insulin to be released. Where type 2 diabetics, they may or may not have lots of insulin floating around their blood, but their body is just starting to ignore that insulin signal to bring the glucose into the cells. All right, so oftentimes type 2 diabetes is driven by lifestyle. So people who are obese for long periods or severely obese oftentimes develop type 2 diabetes. So again, this is a lifestyle driven disease in most conditions, where this is more of an autoimmune injury disease in the people who have type 1 diabetes. We're not going to go over every detail here of how you prescribe exercise. We haven't done it so far, and we're not going to here, but just one note I do want to mention here about diabetics. They're going to need to be testing their blood glucose before, after, and potentially during exercise to make sure that it is within the normal healthy limits. But again, you're going to have to go to another source for that, because we're just kind of going a brief overview of diseases here that need some special consideration. And then once you learn this, and once you find out somebody has one of these conditions, you're going to have to go and look this stuff up further so you can make sure that you prescribe exercise and you treat them in a way that's going to be safe for that client. Dyslipidemia. So dyslipidemia, kind of like hypertension, is a strong risk factor for developing atherosclerosis. So dyslipidemia means that they have some sort of out of whack cholesterol, fat levels of the blood. All right, so dyslipidemia means they either have the bad cholesterol is too high, or the good cholesterol is too low, or some sort of combination of these. Dyslipidemia can be genetically driven and or environmentally driven. So in other words, bad lifestyle choices. All right, so hyperlipidemia, which is a category of dyslipidemia, means specifically that the bad cholesterol or the triglyceride levels are too high in the blood. All right, so dyslipidemia can also mean good cholesterol levels, and we'll get to that now. So again, dyslipidemia here can be caused by not having enough high density lipoproteins, so enough HDL cholesterol, which is the good cholesterol. So if they have lower good cholesterol than say 40 milligrams per deciliter of blood, that is a risk factor for cardiovascular disease. That is a bad risk factor for cardiovascular disease. If they have greater than or equal to 60 milligrams per deciliter of blood of the HDL, then that is actually a good thing, and that decreases the risk of cardiovascular disease. So either one of these are something you want to take note of. So again, either not enough of the HDL cholesterol, which is bad, or having a lot of the HDL cholesterol, which is typically a good thing. The reason why having a lot of HDL is typically a good thing is HDL is actually the type of lipoprotein that goes around the blood and actually kind of picks up the cholesterol that's being deposited around the body inside the blood vessels. So it's going to lower the amount of fatty streaks in the blood vessels or the severity of them, which is over time is going to decrease the atherosclerotic buildup. You can also have dyslipidemia if you have too much of the low density lipoproteins, the LDL cholesterol, which is the bad cholesterol. So if you have greater than 130 milligrams per deciliter of the LDL cholesterol, that is a bad risk factor for cardiovascular disease. So if you don't have LDL and HDL separated, which is pretty uncommon these days, most facilities that are going to run cholesterol panels are going to get the HDL, the LDL, and maybe even some additional cholesterol forms that they're going to measure. But if you are working with some sort of older facility where they're only going to get total cholesterol, which is essentially the combination of high and low density lipoproteins together, then if the person has greater than 200 milligrams per deciliter of blood of total cholesterol, so again, regardless of type, that is considered a bad thing. That is also a risk factor for cardiovascular disease. While having dyslipidemia is probably not going to change the way you prescribe exercise, similar to if you have hypertension, unless it's very severe hypertension, it's probably not going to change the way you prescribe exercise, but it is something that you and your clients should be aware of so that you can try to correct it in some way through proper diet and proper exercise. Obesity is a lot like having dyslipidemia or hypertension, where it is something that oftentimes leads to a bad situation, a worse situation, specifically atherosclerosis or diabetes. So a person who has a body mass index equal to or greater than 30 is classified as being obese. So again, it's going to increase the risk of having atherosclerosis, but it's also going to increase the risk of developing insulin resistance, which is essentially type 2 diabetes. And it's also going to increase all-cause mortality, which means you're more likely to die from something, whether it's cardiovascular disease, cancer, whatever it is. All-cause mortality goes up when you become obese. Another condition that oftentimes gets talked about with obesity is something called metabolic syndrome. Metabolic syndrome is when you have at least 3 out of 4 of the following conditions. So hyperglycemia, so that means high blood glucose, so essentially diabetes. Hypertension, so high blood pressure, central adiposity or obesity, so what we were just discussing, or dyslipidemia, so again, some sort of issue with your cholesterol or triglyceride levels. All right, so if somebody has metabolic syndrome, that's going to substantially increase the risk of developing some sort of cardiovascular disease. And the issue with cardiovascular disease, besides the fact that it can kill you by itself, is it's going to increase the risk that that is associated with exercise. So that's why a lot of these diseases we're talking about here are somehow linked to cardiovascular disease, atherosclerosis, those sorts of things. Let's spend a few minutes here talking about some issues, some pulmonary issues. So COPD and asthma. So COPD stands for chronic obstructive pulmonary disease, and it's sort of an umbrella term for different conditions, the two big ones being chronic bronchitis and emphysema. All right, so chronic bronchitis is when you have a swelling of the lining inside the bronchioles, which are the tubes inside the lungs that that bring the air in and out when you ventilate. All right, so if you have a swelling of those tubes that the air is going through, that means you're not going to be able to breathe as easily, and that's going to potentially, if it gets bad enough, cause some serious decreases in exercise capacity, maybe even a decrease in your activities of daily living, so your ability to do those and your just sort of general well-being. Emphysema is when you have a destruction of the alveoli of the lungs. So the alveoli are the sacs at the end of the bronchioles where the gas exchange, so the respiration is going to take place, where you're going to get oxygen into the blood and CO2 out of the blood. So if you have a destruction of those alveoli, that means you're not going to be exchanging gases properly in the lungs. Again, this is going to cause some serious decrease in your exercise tolerance as well as just your sort of quality of life, and can potentially lead to life-threatening conditions if it gets severe enough. So, important distinction between COPD and asthma is COPD is non-reversible, which means if you do something to treat it, you're not going to really make the problem better. You might be able to improve their ability to exercise through improving other parts of their physiology, but by exercising, by giving medications, by doing whatever it is that they're doing in order to improve their situation, they're not going to get rid of the swelling of the lining of the bronchioles, and you're not going to rebuild the alveoli. Once those things are damaged, they're damaged for life. All right, so COPD is a really bad condition. Again, a non-reversible condition here. When you talk about asthma, asthma is not a form of COPD. It's a different disease. It causes some similar symptoms sometimes, but the key difference here is it's reversible. All right, so asthma is reversible swelling of these smooth muscles that contract around the bronchioles. All right, so again, the same vessels that were swelling with chronic bronchitis are affected with asthma. So when you get an asthma attack, they are affected, and it's going to cause constriction, making it harder to breathe air in and out of the lungs. The difference here is, again, asthma is reversible if you give some sort of inhalant that's some sort of drug that's going to cause those smooth muscle cells inside the bronchioles to relax. All right, so if you cause them to relax, the bronchioles dilate again, and you can get air in and out properly, which is why people who have asthma oftentimes use inhalers to cause a little bit of dilation of their bronchioles. Again, chronic bronchitis and emphysema, which are the two conditions underneath COPD, are non-reversible. Asthma or asthma attacks is reversible with medication. Most people who get asthma, it's going to be brought on by something that's a trigger. Okay, so oftentimes exercise is a trigger, but also allergens and cold air can be triggers. They're very common triggers. So talking about asthma here, because for people who have exercise-induced asthma, you want to make sure that they have their dilators, so their bronchial dilators with them. So basically their inhalers should be with them while they're exercising in case they have an asthma attack. Some people even need to take a puff of their inhaler before they start exercise. These are conditions of the pulmonary system that you need to be aware of, whether or not your client has them, because it's going to affect their ability to exercise safely, and it's going to affect how much they can exercise and tolerate. Talking more about pulmonary disorders here, almost every condition that we're going to be talking about here that is some sort of disease or syndrome is actually going to be improved by a proper dose of exercise. Unfortunately, pulmonary diseases do not, which is something I quickly mentioned before, but you're not going to fix pulmonary disease with exercise. You can improve quality of life, you can improve exercise tolerance with exercise, but you're not going to actually help to fix the disease. All you're doing is basically building up the other physiological systems that work with the pulmonary system and making them better, which is going to make the pulmonary system less crucial to doing exercise or activities of daily living. And so you can tolerate things a little bit better. If you want to learn more about working with adults that have pulmonary disorders, you can look at the resources for the Exercise Physiologist, the second edition, and you can scan this QR code here to see which book I'm talking about. And Table 8.1 is going to go over aerobic training guidelines, where Table 8.2 is going to go over resistance training guidelines. Let's talk about arthritis for a moment. So the major forms of arthritis that we're going to be talking about are rheumatoid arthritis, or RA, and osteoarthritis, or OA. So both of these are some sort of inflammation that's going to happen around the joint. It's going to lead to pain and damage to the joint. So rheumatoid arthritis is an autoimmune disorder. It's going to be a chronic inflammation. It's going to be something that is brought on by sort of an abnormality of the way their immune system is interacting with the joints and the joint capsules and the connective tissue of their body. And in doing so, it's going to damage those tissues, causing, again, pain. It's going to cause morning stiffness. It's going to cause fatigue. And all those things are going to be lessened. All those symptoms are going to be lessened by an appropriate exercise prescription. Generally speaking, with rheumatoid arthritis, you want to prescribe moderate intensity exercise that's going to cause little to no joint damage. So things like aqua aerobics are really great for these people because it's going to decrease the strain on the joints. All right, osteoarthritis is going to be caused by very different issues. So again, rheumatoid arthritis was an autoimmune disease. Osteoarthritis is simply a mechanical injury to a joint tissue that happens over repetitive bouts of stress. All right, so most people, if they live long enough, are going to develop osteoarthritis simply because as you age, your joints age, and that repetitive injuries or that repetitive stress on the joints just from the regular lifetime activities is eventually going to wear away that joint. And so exercise should be prescribed for these individuals when they are having the lowest level of pain they're going to have in the day. You probably also want to adjust the exercise time to be wherever their medication is at its peak, if they're on medication. So they get their medication, let's say 3 hours later it peaks, and when it peaks, they're going to have the least amount of pain. So that's when you want to exercise these individuals. Because osteoarthritis is the result of damage over time from sort of overuse of a joint, you want to make sure that you're not overusing the joints further, causing additional damage. So avoid movements that cause severe pain, because that's a sign that there might be damage being incurred by the exercise you're doing. And also avoid doing high resistance loads or high impact exercise. So these aren't the people that you want to be doing something like plyometrics with. If you want to learn more about exercise prescription for people who have rheumatoid or osteoarthritis, you can look at Table 9.8 in the Resources for Exercise Physiologist second edition, and you can scan this QR code here to see which textbook it is I'm talking about. Osteoporosis is when you have a lower amount of bone density than what is considered healthy. All right, so basically what we're talking about when we say low bone density or low bone mass is you're going to have a deterioration of the bone's microarchitecture. And so that's going to basically, they're taking away, think of like a building. All right, so if you have a building, you have all these pillars that are holding the building up. If you start taking those pillars away, eventually you're going to take enough of them away where the building is going to be very easy to topple over and break. All right, so the same thing happens with our bones. So if you take away enough of the bone microarchitecture, you're going to make the person much more likely to get a fracture or a bone break of some sort. And so some of the things to keep in mind here is that eating enough calcium and vitamin D, or being exposed to the sun enough to develop your vitamin D in your skin, is going to help decrease the risk of developing osteoporosis. Also, doing load-bearing exercise is going to decrease the risk of developing developing osteoporosis. And really, it's a combination of these two. So you need to get the right nutrition as well as the right exercise, because no matter how much you eat calcium and vitamin D, if your body doesn't feel the necessity to build up the bones architecture inside the bones, so build up those extra columns of support, essentially, it's not going to do so. The only reason your body is going to build something is if it is experiencing strain and stresses that it's going to sense and then cause itself to sort of build to deal with those strains and stresses. Again, you need to have both the calcium, the vitamin D, and the load-bearing exercise, so both the nutrition and the exercise, in order to build bones properly. All right, so I want to also mention here that there's a bit of an age component here. So most people that you talk to who have osteoporosis are going to be very old, and there's a reason for that. So most young people are still building bone. Typically, you're going to see a peak bone mass somewhere around 30 years of age. So before you're 30, you're still building bone. After 30, your bone is slowly coming down and deteriorating over time. And so after 30, it's not your goal isn't so much to build bone for most people. Your goal is going to be to minimize bone loss. All right, so young people, your goal is to build up bone so that you have as much as possible. Older people, your goal is to decrease how much bone loss you incur. So there's that threshold. It's typically around 30 years of age. So most young adults don't realize how important the proper exercise and nutrition is for their bone health when they're older. Another quick note here about growing and maintaining bones through exercise. Your bones are only going to grow when you stress them, and they're also only going to grow in response to the stresses that you put on them, the specific stresses you put on them. So in other words, it's going to be site-specific, it's going to be direction-specific, and it's going to be magnitude-specific. All right, so if you only load your bone in the single direction, in a single way, and that's all you ever do, it's going to get really good at resisting that. But as soon as a new stress happens, so if you trip and fall, that's not a stress that most people place on their bones on a regular basis, and so you're still going to have weak bones when you get older, because you need to put stresses on the bones in different ways. Again, your bone's only going to grow to protect itself against whatever stresses it sees on a regular basis. If you want to learn more about exercise prescription for the treatment and or the prevention of osteoporosis, go ahead and look at table 9.12 in the resources for the Exercise Physiologist 2nd edition, and you can scan this QR code here in order to see which textbook I'm talking about. All right, let's switch gears here. So we've been talking about a lot of sort of native conditions and diseases and syndromes, and now we're going to talk about normal populations that just have some special needs to them. So let's talk about children first. So children, young individuals, they're not just young adults. All right, they do have, or they're not just small adults. They do have their own special needs. So some things to keep in mind here: children have higher heart rates at the same exercise intensity as an adult. They have lower stroke volumes at the same exercise intensity as adults, which means if you're trying to compare an adult to a child, you're going to have very different numbers for their cardiovascular responses, and it's going to be hard to do a direct comparison, and it's probably not appropriate to do so. Another note here about their physiology is they're very, very bad at thermoregulation. So thermoregulation means temperature regulation in the body. So they're going to lose body heat and gain body heat much more than somebody who's an adult whose their systems are sort of built up already. All right, so they're not going to tolerate cold well. They're not going to tolerate heat well. So you want to make sure that you're protecting children from exercising in extreme temperatures. Children really need to be getting at least 60 minutes of moderate intensity exercise every day, and at least 3 of those days really should have some vigorous activity involved in that. So they need a lot of exercise. And again, adults need a lot of exercise too, but we just accept a slightly lower threshold for adults. But for kids, again, you really need to encourage a lot of physical activity every single day with kids. All right, so you also need to include muscle and bone strengthening exercises. So a lot of people for a long time are very scared to prescribe resistance type exercise for kids, but they still need to be doing this. They need to be growing their muscles. They need to be growing their bones. And the only way for that to happen is to stress them. Now that you should be trying to make it fun. Kids should be enjoying exercise. It shouldn't be work the way a lot of adults adults face exercise as. So again, make sure they are getting at least 60 minutes of muscle and bone strengthening exercises. So again, we're talking basically resistance training exercise at least 3 days per week. With kids, it's very difficult to define exactly the exercise prescription they should have. You can certainly write an exercise prescription for them, but you need to have a lot more leniency for sort of change in the moment. So you got to be a lot more flexible. Let the kid do some self-regulation, especially with the exercise intensity and duration. So if a kid gets tired, let them lower the intensity, or if they're really tired, let them stop. All right, they will know when they're too tired to continue. And we're talking specifically here about young kids, where they're not going to follow instructions all that well, and you don't want to overexert them. But most young kids, if you just set up some fun activity for them, they're going to push themselves as close to their safe limit as they can, just because they want to go out and have fun, they want to play. So just encourage that play as much as you can. All right, so the real goal with kids is not necessarily to have them exercise. They should be doing that just with play, essentially. The real goal is to limit their sedentary time so they are as active as they can be, and just happy kids and enjoying their youthfulness. And so that's something that you should be promoting. On the other end of the spectrum, we have older adults. All right, so we oftentimes think of getting old as sort of getting bigger, getting more body fat, but I want to you to keep in mind here, increased body fat is largely due to inactivity, not aging. Neuromotor function also declines with age, and so that's essentially your coordination, your speed, your agility, your balance. Those things are going to decline. So neuromotor function and neuromotor exercise is super important for people who are aging. So again, think of things like yoga, think of the martial arts, things like Tai Chi. Really, really good for older individuals to prevent this loss of sort of neuromotor control of the muscles. Like kids, older adults lose a lot of their ability to thermoregulate, which means they're not going to tolerate heat very well, and they may not tolerate cold very well either. So make sure that you're exercising them within a fairly thermoneutral environment, something that's very comfortable for them to exercise in. Older adults are also going to develop a decreased cardiovascular or cardiorespiratory and metabolic abilities as they age. So they're not going to be able to pump as much blood around the body. They're not going to be able to exchange as much oxygen because they're not pumping as much blood. And they're also going to decrease their metabolic ability. A lot of these things can be negated to a large degree with exercise, but just keep in mind that most older adults that you're going to deal with are going to be not as good at this as what you would see in a younger adult. So some things you probably already know, but they're worth mentioning here. Exercise is associated with improved health, improved fitness, and improved cognitive, so basically brain power of older adults. So it's really, really good for older adults. It's good for everybody, we know that, but it's especially good for older adults. So it's important to make sure that you're having your older adults that you're working with exercising, and basically the goals and the recommendations are the same as for younger adults. The only difference is they may be starting at a severely deconditioned state, and if that's the case, just make sure you lower your expectations, especially your initial expectations. Start them at a nice low baseline and progress them a little slower than what you do with younger adults. But again, the goals are really the same. You want to get them the same Fit VP principle that we talked about prior in the cardiorespiratory section, as well as in the muscle fitness and flexibility sections of this course. Another thing that happens all the time is we are going to eventually need to deal with a female client that has become pregnant. So when we get pregnant, it's a normal part of life. It's required for our species to continue, and it's something that does not mean they should not be exercising. So it is safe, and it is actually highly recommended for women to exercise while they're pregnant, assuming it's a normal pregnancy. If it's some sort of complicated pregnancy, then that changes things. So in a normal, uncomplicated pregnancy, the woman definitely should be exercising throughout the pregnancy. If a complication arises, they should be working with their healthcare provider to determine if it's safe for them to exercise or not. Some things that are worth mentioning here, if vaginal bleeding, shortness of breath prior to exertion, or very unusual shortness of breath with exercise. Some shortness of breath is expected, especially in the later stages of pregnancy, but severe shortness of breath should be discussed with their doctor. Dizziness, headaches, chest pain, muscle weaknesses, calf pain, swelling, preterm labor, decreased fetal movement, which is a big important one, leaking amniotic fluid, any of those things, if any of that occurs, they really need to talk to their doctor. Make sure that they're not experiencing something that is going to suggest that the baby is at risk or they themselves are at risk, and the doctor will tell them whether or not they need to be worried and whether they can continue to exercise or not. So if any of these happen, stop the exercise, have them go talk to their doctor before they restart their exercise program. Keep in mind though, even though we mentioned some things like shortness of breath with exertion, women are going to have lower exercise thresholds, especially in the late periods of their pregnancy. So they're going to have a increase in their submaximal heart rate, and they're going to have a decrease in their maximal heart rate. So they're often working at a higher level of their capacity after they've become pregnant than before they were pregnant, working at doing the same exact exercise bout. So expect some decrease in exercise tolerance, especially later on, and sort of build in a lot of flexibility. You don't want to overstress a pregnant woman. That's not good for them or their baby. So make sure that you're not being super rigid, super pushy with the sort of exercise prescription. Have some give, have some flexibility. Just encourage activity as much as you can though. When women are pregnant, they're going to be growing in directions that they're not used to growing, and it's going to shift their center of gravity, and it's going to make them more likely to fall. Bicycling is probably not such a good idea later in the later in the pregnancy, and definitely other things. You know, if you're working with gymnasts, you probably don't want them on a balance beam or anything where there's a chance where they're going to fall or hit their stomach with any sort of object, or trip and fall and land on their stomach. Anything that hits the stomach, it brings about a lot of risk for the baby. So make sure that you're prescribing exercise that is safe, that they're not likely to trip, fall in any way, or have something land on them. So while the recommendations I'm giving are very generic recommendations, they should definitely be talking to their medical doctors to get better recommendations or specific recommendations for them. Just keep in mind the typical pregnancy is going to gain about 26 pounds, give or take there. So expect quite a bit of weight gain, and also expect that they're going to need more calories per day. So in the first trimester, usually you need about 150 calories per day more than what you would need prior to being pregnant. And the second and third trimester, you're going to need about 300 calories per day more than what you would need when you weren't pregnant. So they do need to eat more. They should expect a fair amount of weight gain, reasonable amount, but a fair amount. So don't try to minimize that weight gain unless their healthcare provider has told them they've gained too much weight with their pregnancy and they need to lower it a little bit. But let the medical supervisor or their medical professionals that they're working with determine if they've gained too much weight, and help sort of work with them if possible to make sure that the woman is as healthy as possible. Some special considerations here. This is a very short list. This list could be much, much longer than this, but some things to avoid with pregnancy. And I'm going a little more detail into this because it's a much more common thing that you're probably going to work with at some point in time. So teach proper breathing. Don't allow pregnant women to do the Valsalva maneuver, which is basically when you hold your breath and kind of push and you don't allow the air out. So it's very common that people do this when they do resistance training. Don't let them do that. It's going to increase their blood pressure. It's going to increase chances of some sort of hypertensive-like symptoms, so dizziness and other things. And it could cause some issues if somebody is at risk and they don't know it, with sort of cardiovascular disease type of events may occur with this elevation in blood pressure, because it can be a pretty severe elevation in blood pressure. Also, avoid supine or prone exercise after the first trimester. So supine means laying on your back, prone means laying on your stomach. The prone, the laying on your stomach, I think is pretty obvious. You don't want to put pressure on the stomach. The supine, the baby's pushing down on the mother's abdomen, and in the abdomen is going to be the inferior vena cava. All right, the inferior vena cava is what brings most of the blood back to the heart so that it can be pumped again to the body. So if you're pushing on the inferior vena cava, it's going to collapse. That means less blood's going to get back to the heart. And if less blood gets back to the heart, less blood gets out to the body, and it can cause symptoms of low blood flow. That is not a good thing for the mother or for the baby. I already mentioned this one, but just because it's on here, let's list it again. Avoid anything that can cause trauma to the abdomen, and avoid anything that's going to be a high risk of falling. Remember, their center of gravity is off. Just because they could do it before they're pregnant doesn't mean they're going to be able to do it while they're pregnant. Avoid overheating. Make sure they're well hydrated. Pregnant women don't tolerate heat nearly as well as they did before they're pregnant. So again, thermoregulation's off with pregnancy. And also avoid exercise that is over 6,000 feet if they are not acclimated and they're not used to, if they didn't live at that level of altitude before a pregnancy. Definitely avoid taking them to those levels and exercising them. At those high levels of altitude, there's a lot thinner air, so they're not going to get quite as much oxygen into their blood, and again, that's not going to be good for the potentially not going to be good for the baby or potentially even the mother. So make sure you avoid high altitude exercise with pregnant women. To see a list of relative and absolute contraindications to exercising a pregnant woman, you can go to table 10.1 in the resources for the Exercise Physiologist 2nd edition, and you can scan this QR code here to see which textbook I'm talking about. Anytime you're working with a client, you need to be aware of the medications they're on, both prescription and over-the-counter medications, because they have the ability to interfere with normal exercise responses, and it can cause both a dangerous situation or just a lower exercise tolerance. So you need to be aware of what they're on. Look up anything that you're not familiar with. Talk to the client, find out what it's for, and make sure that you know what it is that's going to happen when they exercise on that medication, and make sure that the client knows signs and symptoms they need to look out for and alert you to if they were to occur. So again, there's potential side effects and interactions between exercise and a lot of medications, including the over-the-counter medications. Be especially careful with the over-the-counter cold and flu medications. They're probably going to have something called ephedrine in them, or a similar drug, which is likely to increase blood pressure, which is going to increase the risk of cardiovascular events during exercise, especially in at-risk individuals. Also avoid exercising diabetic patients when they're on medications that are going to have alcohols and sugars in them, because that's going to affect their blood glucose levels. Now, you might be able to get away with it if it's very controlled diabetes, but definitely make sure you're at least testing the blood glucose before, maybe during, and especially after exercise, to make sure their blood glucose levels are at safe levels for that client. A similar thing to keep in mind is supplements. So just like medications, supplements can interfere with the normal responses to exercise, interfere with exercise tolerance, and the big difference between supplements and those other medications is supplements aren't regulated very closely the way that other medications are, so we often don't really know how the body is going to respond to supplement use. So if somebody's on a supplement, some sort of dietary supplement, make sure that you're especially careful when they go on to something new, and that you watch them closely. And again, you want to look up, see if there's any known side effects or potential side effects of the supplements they're on, and talk to them about what they're on, why they're on it, what it's for, so on and so forth. Just be very aware of the situation. All right, so that was a really, really basic overview of some special populations and special situations where you need to do a little extra digging to find out information before working with that client. All right, so again, we didn't really go over the exercise prescription. I talked a little bit about a few details here and there, but I really just did an overview of conditions that you need to be aware of and that you need to look out for, and kind of throw up a red flag and just say to yourself, I need to go look up more before I work with this client, because all of these conditions conditions that I talked about are conditions where the individual could be at risk, or you may be putting, in the case of pregnancy, the unborn child at risk if you exercise them in a way that is not safe for them in their condition. So again, very quick overview, definitely not an all-encompassing overview, because this is something that really should be done over several lectures, or maybe even up to an entire semester long course. So if you have any questions, I can try to get back to you on those. I know, again, this was a broad topic. You can put those in the comment section below and I'll try to respond to those. Otherwise, please come back and watch another video. Thanks.